Hello, ladies and gentlemen. Thank you very much for the kind invitation to participate in Cardiolibia 10. And thank you so much to the Libyan Cardiac Society for letting me discuss with all of you the 2023 ESC guidelines for the management of endocarditis. These are my conflict of interest, and I was very honored to be one of the chairs together with Michael Borger for these ESC guidelines, where you can see that the task force members are quite diverse in terms of specialty, since this disease is a disease that comes to any ward of the hospital, doesn't need to come directly to cardiology. It can be diagnosed in neurology, in orthopedics, or any other ward, since many times we have the consequences of, for example, an emboli or the complication of another infection. So as you can see, we have specialists that cover cardiac imaging, clinical cardiology, microbiology, infectious disease specialists, cardiac surgeons, cardiologists with a specialty in electrophysiology, in congenital heart disease, in transcatheter interventions, and also with rheumatic heart disease, for example. These guidelines bring 42 new recommendations. There are upgraded antibiotic prophylaxis indications so that there are no inconsistencies between both sides of the Atlantic. So we are in agreement as well with the American Heart Association guidelines. We propose the modified new diagnostic criteria, giving more emphasis on imaging findings that many times come before the microbiology proof and the positive cultures, which doesn't mean that with that we have the diagnosis. We still need to have the proof that there is an infection. So the blood cultures and the microbiology proof is important. One of the most important changes was the paradigm change in terms of oral antibiotic therapy, and having the possibility to do outpatient or partial oral endocarditis treatment in the outpatient clinic. The definitions of timing and indications for surgery have been clarified. And then there are specific clinical scenarios, such as, for example, patients with infections in pacemakers, pregnancy, or other situations where the guidelines try to streamline what would be the diagnosis and the management. This is the central figure of the endocarditis, where one of endocarditis guidelines, where one of the most important concepts that we need to keep in mind is the endocarditis team. And remember that this endocarditis team has a nucleus composition where there is cardiologists with clinical expertise and imaging, preferably a cardiac surgeon and an infectious disease specialist and or microbiologist. And on top of that, there can be other specialists that can provide their expertise in order to optimize the management of the patients. This endocarditis team can be very large, can be very small, and it needs to be adapted to the different environments where we are. Thinking that there are centers that are not the so-called heart valve centers where all the resources are available in terms of diagnostic and therapeutics. There can be a more regional or more secondary level hospital, but there needs to be a good communication with the third level hospital to provide a timely diagnosis and treatment of these patients. Starting with the prevention of endocarditis, that's the most important, to avoid that this complication happens, because it's a rare condition, but a major public health challenge, with an incidence around 14 per 100,000 patients per year, with devastating consequences and in terms of death and also disability adjusted life years. And the guidelines try to classify the population according to the risk of having this complication. There are individuals with a low risk, individuals with intermediate risk for whom we have to strengthen the preventative measures, but I would say that those preventative measures are also important for the low-risk population. We never know when we are going to have a cardiac condition that could lead to an endocarditis. And then there are the patients with high risk for whom antibiotic prophylaxis before an intervention or a diagnostic test that can lead to bacteremia, they need to have that antibiotic prophylaxis. What do we have in terms of supporting the evidence that support the recommendations of prevention or the use of antibiotic prophylaxis? So we need to rely on observational data on large registries, because having a randomized clinical trial is going to be very difficult, and we will need many patients or many individuals, and maybe we don't get meaningful results, because, as I said, it's a rare condition. But there are certain groups that have higher risk. These are patients that have had a previous infective endocarditis, a prosthetic valve, a valve repair with prosthetic material, corrected congenital heart disease, but also a non-corrected congenital heart disease with a shunt or a conduit. These have the highest risk for infective endocarditis and the highest risk of death compared to the reference population that will be the low risk. Then there are moderate risk conditions, such as previous rheumatic fever, non-rheumatic valve disease, or congenital valve abnormalities that do not fall into the category of cyanotic congenital heart disease or congenital heart disease with prosthetic material or with a shunt or a conduit, where you can see that the incidence of infective endocarditis is higher than for the reference population, and the mortality is also not deniable. And then there are unknown conditions for whom the risk of infective endocarditis is high. Particularly think about patients with LVADs, with a left ventricular assist device for a destination therapy, or patients with hypertrophic cardiomyopathy, or patients with implanted pacemakers or cardioverters, who are many. Compared to the reference population, the risk of infective endocarditis is higher. But in terms of mortality, we have more data for pacemakers, and it's not as high as the previous conditions that are here in this graph, but certainly is higher. So sometimes to decide who to recommend antibiotic prophylaxis is very easy when it's a high-risk condition. But for a moderate risk condition and unknown conditions that sometimes the risk is also associated to the clinical condition that the patient has, patient with an LVAD that has an endocarditis, is going to be very difficult to operate if needed. So it's difficult to make the recommendation. So patients with high risk, with previous infective endocarditis, with prosthetic valves, specific patients with congenital heart disease, cyanotic congenital heart disease with repair and significant amount of prosthetic material, or conduits or shunts. And then patients with ventricular assist device as a destination therapy. Why? Because these patients, in case they need intervention, these are very high operative risk. Then we have the intermediate risk patients, who are patients with rheumatic heart disease, non-rheumatic degenerative valve disease, congenital valve abnormalities that are not in the previous category. Think about a bicuspid aortic valve, cardiovascular implanted electronic devices, and hypertrophic cardiomyopathy. So for patients with a high risk for infective endocarditis, all have a class 1 recommendation of using antibiotic prophylaxis prior to orodental procedures at increased risk. And also in patients with ventricular assist devices. For patients, for example, with transcatheter mitral and tricuspid valve repair, the need for antibiotic prophylaxis should be considered. So it's a class 2A recommendation. It's different from patients with transcatheter aortic valve implantation, a TAVI, that belong to the high-risk patients. Class 1 recommendation then for antibiotic prophylaxis. Patients with heart transplant, antibiotic prophylaxis may be considered, and antibiotic prophylaxis is not recommended in other patients at low risk for infective endocarditis. Now, there is a situation that has been upgraded compared to the 2015 guidelines, that is the use of antibiotic prophylaxis in high-risk patients, always high-risk patients, undergoing an invasive diagnostic or therapeutic procedure of the respiratory, gastrointestinal, genitourinary tract, skin, or musculoskeletal systems. We have put a recommendation to be maybe considered. Why? Because registries have shown that is associated with more frequent infective endocarditis, but be careful with the trials, because sometimes these registries is not only infective endocarditis, can be also bacteremia. So there is always a confounding factor that makes difficult for us to upgrade more. The indication needs to be a tailored procedure for each patient. In terms of the doses to be used for antibiotic prophylaxis in patients without allergy to penicillin or ampicillin, we will use amoxicillin, ampicillin, cefazolin, or ceftriaxone. And here you can have the doses for adults and children, and it's a single dose 30 to 60 minutes before the procedure. If there is allergy to penicillin or ampicillin, then you have cephalexin, azithromycin, clarithromycin, or doxycycline, and cefazolin of ceftriaxone. And the one that has been eliminated here is clindamycin. Does it mean that we cannot use it? No. You can use in case that's the antibiotic that is available in your region, but because of the associated risk of complications and at the level of the colon, then it has been removed or has been considered that preferably not use it. But if it's the only one that is available, then you can use it. In terms of diagnosis of endocarditis, basic clinical suspicion. If we don't suspect that, we will miss it. Consistent microbiological data and infective endocarditis related cardiac lesions by imaging. These are the kind of the triada for diagnostic infective endocarditis. And the guidelines still keep major and minor criteria and classified infective endocarditis as definitive, possible, and rejected. And we have tried to come with specific diagnostic algorithms for native valve endocarditis, prosthetic valve endocarditis, and endocarditis related to the presence of cardiac implanted electronic devices, pacemakers, and ICDs. These are the major and the minor criteria. Major criteria: blood cultures positive for infective endocarditis with typical microorganisms such as oral streptococcus, Streptococcus galolyticus, that was the previous bovis, Hasse group, Staphylococcus aureus, and Enterococcus fecalis. And then microorganisms consistent with infective endocarditis from continuously positive blood cultures, at least 2, with blood samples drawn more than 12 hours apart. And then the imaging positive for infective endocarditis, where we not include only echocardiography, but think about other tests that the patient may have because the patient has been admitted. In other words, and the lesions that we have suggest that the patient may have an endocarditis. Imagine the patient that comes with a stroke, with fever, and the brain CT shows that there are multiple lesions. Well, think about endocarditis, perform an echocardiogram. Minor criteria: predisposing conditions, fever, embolic vascular dissemination, immunological phenomena such as glomerulonephritis or Osler nodes and Roth spots, and rheumatoid factor, and then other microbiological evidence. Think about microorganisms with a slow growth and positive cultures that do not meet the criteria that is in the major criteria. And then you have the serological evidence of active infection with organism consistent with infective endocarditis. 2 major criteria, 1 major criteria, and at least 3 minor criteria, or 5 minor criteria, make the diagnosis of infective endocarditis as definitive. So this is the basic clinical suspicion, blood cultures, and imaging. And the first imaging technique that we are going to use is transthoracic echocardiography. But if there is any suspicion in the transthoracic echocardiography, or if you don't see anything, go to the transesophageal echocardiography to make sure that those lesions can be seen. And here, echocardiography that we use is 2D echocardiography and can give us a lot of information, but 3D echocardiography can also provide very good imaging characterization of the destruction of the valve. Here on 2D, for example, we can see that there is a vegetation at the level of the commissure, but actually this patient not only has this vegetation at the level of the commissure, has also a perforation that we can see here with the color. So the level of destruction that we can see with 3D echocardiography is sometimes more than what we all use 2D. These are the three algorithms for native prosthetic valve endocarditis and CID endocarditis, and we will go through them with examples. This is a 46-year-old man known with a bicuspid aortic valve since 5 years ago that was diagnosed in a regular checkup and has a mild aortic stenosis. The patient has a bike accident and had to undergo for dental implants. So is there any one of you that would have used antibiotic prophylaxis in this patient? This could be a moderate risk, so it's not recommended initially, maybe consider. But the patient 1 week later consults to the GP because of fever, shivers, feeling unwell and pale. The patient didn't use antibiotic prophylaxis. He has a heart rate of 95, a fever, a blood pressure of 130/40, and a new aortic diastolic murmur. On the lab, there is inflammatory markers, leukocytosis, and the blood cultures are 4 of them positive for Streptococcus viridans. And here you can see a mass that is coming into the LVOT with a very severe aortic regurgitation. So that makes probably diagnosis of endocarditis with clinical suspicion and 2 major criteria. One is the blood cultures that are positive, and second, the endocarditis. We stop here and we go for surgery. Well, that we'll need to see. And preferably, after a transthoracic that is positive, a transesophageal echocardiography needs to be performed. Why? Because it will tell us with more precision which is the size of the vegetation, which is a parameter that is important for the risk stratification of this patient, the severity of the dysfunction, and also if there are other lesions such as abscess or other complications. Why is important? Because with that, we can have the algorithm for treatment of infective endocarditis. There are 3 indications for surgery: heart failure, uncontrolled infection, or high risk of embolism or established embolism. And we have emergent surgery within the 24 hours, urgent surgery within 3-5 days maximum, and then non-urgent surgery. And in this case, we have a patient that has vegetation. There are no abscesses. There is severe regurgitation. The patient is not in heart failure, so let's going to go into this schema. The vegetation was 18 millimeters. The indication says that if the vegetation is at least 10 millimeters and there is already embolism, despite the appropriate antibiotic therapy, urgent surgery is recommended. If the vegetation is at least 10 millimeters and there is another reason for surgery, that in this case would be the severe aortic regurgitation, urgent surgery is also indicated. But if the vegetation is more than 10 millimeters and there is no evidence of embolus and there is no other indication for operation, we could wait and continue with antibiotic therapy and checkup. And this links very well with the changing paradigm of antibiotic therapy, of treatment of antibiotic therapy that we have proposed also in the guidelines. The cutoff value of the vegetation of 10 millimeters has been demonstrated in several registries, and one of these registries is the EuroEndo, a registry from Europe, and that showed that the larger the vegetation, particularly more than 10 millimeters, higher the risk for embolic events or 30-day mortality. Moving towards to the prosthetic valve endocarditis, this is another example. Patient with an aortic valve replacement 1 year ago, diagnosed with a colon carcinoma, has presented with fever and loss of weight, but the transthoracic echocardiography is negative and the blood cultures are negative. What do we do here? Because has high suspicion of endocarditis, we do a transesophageal echocardiography, and here we can see very thickened leaflets. This is not the normal appearance of a prosthetic valve, And also the aortic root seems like a little bit sloggy and thickened, as it would be the formation already of an abscess. If we have any doubts, we can also perform a CT scan, and this one can help us to see these vegetations, this thickening of the leaflets, but also this mass around the valve that should not be seen after 1 year of surgery. But we can perform other tests, for example, a PET-CT if we have access, because also will give us an overview of the entire body, can give us also information about the portal entry of the microorganism and whether there are also embolies or not. And then moving to the CID infective endocarditis, this is a 77-year-old man with a pacemaker due to complete AP block, put infection on his hand, presents with fever, loss of weight, and blood cultures that are positive for aureus. And here you can see in the transthoracic echocardiography a big vegetation, probably adhere to the pacemaker lead, but we don't know if there is also affection of the tricuspid valve. Anyway, what we can do in addition to the imaging is to perform a PET-CT. Why? Because here with the PET-CT, we can see whether there is infection of the pocket. And if there is infection of the pocket, the recommendations for management of cardiovascular implanted electronic device-related infective endocarditis have a class 1 indication for removal of that ICD or pacemaker, and then treat accordingly with antibiotic therapy until reimplantation. So that has implications. Finally, for the management of infective endocarditis, I would like to highlight the collaboration between the two endocarditis teams when we have centers that do not have all the expertise to treat those patients, and the indications for referral to those centers in case there is a complicated clinical evolution, and it's a schema that can be used in order to organize the network that will help to manage these patients. In terms of antibiotic therapy, what I would like to highlight is the new outpatient paradigm for antibiotic therapy, and this is based on the results of the POET trial. Outpatient parenteral or oral antibiotic therapy should be considered in patients with left-sided infective endocarditis caused by one of these microorganisms, Streptococcus, Enterococcus faecalis, Staphylococcus aureus, or coagulase negative microorganisms who were receiving appropriate intravenous antibiotic therapy for at least 10 days or at least 7 days after cardiac surgery, are clinically stable, and who do not show signs of abscess formation or valve abnormalities that would require surgery on transvaginal echocardiography. And as a class 2A recommendation, all the other patients that do not fulfill any of these criteria should be continued with intravenous antibiotic therapy in the hospital. So this is the phases of the antibiotic therapy. We have the early critical phase where you should have inpatient treatment with intravenous rapid bactericidal combinations and cardiac surgery if needed for removal of the infected cardiac devices and draining the abscesses. And then you count 10 days and you perform a transesophageal echocardiography prior to switching the intravenous antibiotic through oral therapy. And that will lead you the option that if there is no complicated situation, the patient is clinically stable and the infection is controlled, then you can have the continuation phase with resting bacteria, where you can have OPAT or oral antibiotic therapy. This is the schema to ask which is the microorganism. Is one of them? Yes. Second question, is the infection controlled? Yes. Is there any situation of the patient that will lead to a malabsorption or not appropriate effectiveness of the antibiotic therapy? No. Then you perform a transesophageal echocardiography, and if there is no new surgical indication, the patient can be switched to oral antibiotics. So these were the data shown by the POET trial. showing that there was no, the oral treatment was non-inferior to the intravenous treatment, and the oral group could be discharged 17 days earlier. And this has been demonstrated as well in the 5 years follow-up. So here there is an example. It's a patient, 63-year-old man, diabetes, atrial fibrillation, and vegetation or endocarditis of the aortic valve because of Streptococcus agalactiae, and with a vegetation that no complications, no emboli, and after 17 days of antibiotic therapy, the vegetation has reduced significantly, the valve is not dysfunctioning significantly, patient has no fever, the patient can be changed to oral antibiotic therapy. So this is one of the main changes of the guidelines in 2023. And this has been also demonstrated in the follow-up at 5 years of the POET trial, showing that oral step-down antibiotic therapy is actually associated with better outcomes than intravenous in the hospital. So in conclusion, antibiotic prophylaxis is strengthened in high-risk patients in these new guidelines. The diagnostic criteria strengthen the role of multimodality imaging, not only echo, and the antibiotic treatment in stable patients without indication for urgent surgery is a possibility, but always think about the stability of the patient and no new indications for intervention, and therefore the transesophageal echocardiography is mandatory prior to change to oral antibiotic therapy. And if you want to know more about the role of imaging in infective endocarditis, I wait for you at EuroEcho Imaging this year that will be in Berlin. Thank you very much for your attention.